Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Tom, good to see you again.
Parker, nice to see you. Is this the first time we've done a podcast shoot on a Friday?
I think it is. Happy Friday.
Happy Friday. Happy Friday. I think Memorial Day holiday, and then we did sort of a special episode yesterday. But yeah, so I it's always nice when it's Friday, so it's nice to be recording on a Friday.
Yeah, it's funny you mentioned that we recorded our special episode yesterday, which was for a guest episode that we did with Dr. Steve Kachi. However, this episode that we're recording now is going to release before that episode. So those listening now know what to expect for next week's episode. So
there you go.
All that being said, this is the Sit and Stay podcast. You are joined by Parker Anderson, who is myself. I'm the product manager here at RipsyTech, and I'm joined, as always, by the illustrious Tom Tarshis, founder of RipsyTech. So
I hear
Tom,
the Friday coming through in your description of myself as illustrious. I appreciate that.
Yeah, Casual Friday, Praise Your Boss Friday, whatever you want to call it. So today we wanted to talk a little bit about streamlining payment collection, which is a really big topic. It's every provider has to do it, whether they're taking insurance or not. You still need to collect payments in some way. So just to get the ball rolling on the topic, we wanted to talk about very common challenges that mental health practice face when they are undergoing payment collections. So what are some common challenges and how can these be addressed?
Yeah. And, probably one of the most central pieces to starting any practice or any business is you got to get paid and you need revenue for your business. And I think talking about a couple things before we get into some of the challenges is, number one, noting things are a lot easier now than they were, say, in the early 2000s or even 2006 when I first had to take patient collections. Because back then, you had a lot of people writing checks. If you took credit cards, you had machines that you had to swipe. There was no such thing as hold your phone to a terminal.
Oh, right. Apple Pay.
Correct. None of that existed. And you even had they were still giving out the backup slider paper credit card slips at that time for if there was a power outage or, your phone line. It wasn't even through internet then. It was sort of you plug a phone line into the credit card terminal and it dials and approves it. So it is very cool that technology has made this process easier. So that was the first thing I wanted to comment on. And I think the second piece to comment on, especially in a field where the majority of practitioners do not accept insurance, or even now if you take insurance, but with the rise in high deductible insurance premiums, is that you're often collecting pretty large sums of money from people who are coming to you for help. And this is something a little bit unique in the American health insurance system. For example, in Europe, when you go, the money for your healthcare comes out of your taxes. There's no extra collections at the doctor. And it creates one less, I think, barrier on both sides of treatment.
Right.
And it's there's ethics and other discussions and PhD dissertations on healthcare as a right. There's, as we've talked about, mental health care reimbursement has not been handled the same way as in other medical specialties. And that's part of the reason for the high number of people that don't accept insurance. But what that means is you're going to have times where you're collecting hundreds or thousands of dollars from your patients who are usually coming to you in mental health crisis for themselves or their kids. And that's a lot of money. And money is a big stressor for families. It's a big stressor for people. And, for me personally, even from the beginning, I've always felt it always feels a little awkward collecting that money. It feels much better to me to collect the $20 copay.
Right.
But you're exchanging that comfort for a whole lot of other heartache lots of times with the insurance company. So just wanted to point out the, sort of ethical or philosophical issues in this country you have to face with collecting payments from your patients that you're trying to help. Yeah, and I don't know, Parker, how you feel, when you go for a blood draw or to see a doctor, how much you've interacted with the healthcare system and.
Right. I mean, in an ideal case, they know exactly how much money I owe, and they will ask me up front. I've had experiences in the past year where I went to, I can use the eye doctor as an example. I went to the eye doctor. I had to pay a certain amount to have my eyes checked. And then, sometimes it's, depending on where you go, it'll be a separate exam that they need to do if you need contact lenses. And then, that feels like a new thing to me, but I've had it where, I have to pay a lot for my glasses because I've got some kind of special lenses, and I'm there, and all is said and done, and I'm paying them when I'm at my appointment, which feels like a lot of money, and then a couple of months later, I get another bill in the mail saying, oh, you still owe us $30, and I'm like, okay, well, I just paid, much more than $30. So I guess $30 is just a drop in the bucket. I don't want you to come begging or bugging me for more money. So yeah, here's the $30. But then that same provider, I actually got another bill in the mail like a month later saying, oh, actually you still owe us $40. And that to me was like, that just can't be right. I already paid you a ton the first time, and the second time I was like, okay, I understand. Like I work in healthcare. I work with EHRs. I understand that the insurance billing can be complicated, and that sometimes you just don't know how much something is going to fully be reimbursed for at the time of the appointment. But to be reached out to a second time was it was a little fishy. But, I mean, they were very nice. I called them back and I reached out and I said, hey, I just got this other thing for $40. What's up? And they said, you know what? You're right. That is weird. And they just waived it, which is great. That speaks to a good provider if they're willing to do that. But yeah, the experience of just the fact that the system is set up in this way where something like that is open to happening, as somebody who's very interested in user experience, customer experience, it's a bad customer experience.
Yeah, no, and I'm sure everyone listening has experienced a story like that, either from the dentist or pharmacy, vision or medical care, and so it's something that we all deal with. So, and nice pivot from saying begging to bugging, by the way, and then
Thanks.
Yeah, and a good segue into like, well, so that is the problem with your mental health practice, is that there is payment required for every visit for someone who comes into your clinic. So the challenge is, I would say, initially when you have a new patient, as you alluded to, and whether you're in network or maybe you are a cash practice but still submit claims for your patients, you really never know what the cost is for patients with insurance until you submit to their insurance and get that claim back.
Right.
And we have sophisticated tools that can check benefits, that can say, hey, this patient has met this deductible or is not. But unfortunately, the reality is those are only correct most of the time. So for example, those systems rely on communication of all prior visits with respect to if someone's hit their deductible. There are so many different CPT codes and different reimbursements for mental health. Was that outpatient? Was it telehealth? Was it inpatient? Right. That, the information we get back when we do a benefit inquiry through the EHR, it's like my master's degree in statistics is barely good enough to get through it. So we're trying to give patients, hey, we think it will be this much, but we won't really know until we get the insurance reimbursement. For non-prescribers, it can be a little more straightforward because of some of the billing of the therapy codes that are mainly time-based. This isn't totally true because you still have things like interactive complexity, or right. that code that people should be billing for when they can, and that can add an extra cost for the patient. And I think ultimately, the biggest confusion is that there are a lot of factors that can go into changing the amount that someone owes you for a clinical visit. And I think we'll talk more about it a little bit later. But the question you face as a practice is, are you going to take deposits initially? Are you going to charge people at the time of their visit? Are you going to charge them before their visit? If it's a new patient, are you going to wait to charge anything and to see what the insurance reimburses if you take insurance? For patients who come weekly or twice a week, are you going to collect every visit or weekly, or are you going to collect once a month? These are all decisions that, these are all things that different clinics do. And what you have to ultimately decide is what your policy and how your clinic is going to handle letting people know a payment is due.
Yeah, I think just speaking from personal experience of, anytime I see any mental health provider, I think my preferred experience has been if they take my card at the visit, then let's just do that first. Before we even start the session, I'll pay for the session. But then if it's a provider who has my credit card on file, then I would just expect, we have the visit, and then, within a day, I'll see the charge on my bank statement. And that to me is just like very simple, especially when it's, it's in person and it's your provider who is like handing you a credit card terminal. I think it's, for me at least, it's just super simple to do it right off the bat. We don't have to do it at the end. The end is usually reserved for figuring out next best time to visit. Actually, no, the provider I see, we do credit card, when's the next time to visit, best next time to visit, and we just get all that out of the way, and then we just shake hands at the end of the session, and then I'm off. But yeah, there's multitude of ways to do it. I'm sure that my provider specifically found that works best for the patients that he sees, but it's going to come down to being different for every person. But that's just my 2 cents of a positive customer experience.
Yeah, and good comments. And then there are other clinics where, you might have front desk staff where people walk in and there's a terminal to swipe a card, or you might have, right, remote staff that just, reaches out to people on the day of their visits or on a weekly basis to collect. And a lot of practitioners like that better for 2 reasons. One, it doesn't take a few minutes out of the therapy time or the session time with your patients. And 2, it puts a third party between that uncomfortable money exchange.
I will say, that is the more ideal experience for sure.
Yeah.
So, we covered a lot of challenges. Are there any, before we move on to the next question, are there any other common challenges that you think would be good to talk about?
Yeah, I mean, I think a lot is, you know, deciding if you're going to accept credit cards for payment or are going to ask for ACH bank transfers. You know, I wouldn't recommend these days. I think there's very few people who accept cash or check, although that was really the norm even a few years ago. Now, the issue here is the credit cards, you're paying 3 to 4% potentially for every transaction, whereas the ACH transfers, it's drastically less, never more than one. I've never seen it more than 1%, and sometimes much less than that. So if you're, earning $10,000 a month, it feels a lot better to only lose 100 of that to financial transaction fees versus 300 of that if you're accepting credit cards. I think the reality is the convenience of credit cards and knowing that you're getting the bulk of your payment right away is worth losing that 3% fee. But there are, I know a lot of practitioners who actually required Zelle or Venmo, which at this time there is not fees attached to,
right?
That, with an asterisk, and or I'm sure the fees will be coming soon. But that's their only form of payment, and then there is no transaction fee. So,
yeah, I mean that's interesting. If somebody would prefer to use something like Zelle or Venmo, I think the only limitation that I could think of there is, if your patient doesn't have a smartphone, then, maybe have a contingency plan for that. But, yeah, just something that came to mind.
Fair enough. I don't think we've had a patient without a phone, even among our Medicaid population. But, yeah, fair enough.
Yeah. I mean, it's a question of accessibility, especially, if you live in if you have patients who might not have a smartphone or might not have access to a smartphone, it's something to keep in mind.
Very good.
All right, so we've talked a lot about some common challenges. What about this important piece of collecting any amount of payment? You have to have some kind of payment policy in place in order to enforce whatever your method for collecting payment is. So when it comes to communicating the payment policy, what are some best practices for getting that across and making sure that the patient isn't encountering any surprises or, financial misunderstandings?
Yeah, and there's, most people have probably heard of the No Surprises Act that came into effect. And I think we even talked about that on a previous podcast. So there is definitely a legal responsibility to make sure that a patient knows the maximum amount they're going to be paying for the service if there was no insurance coverage. So that information needs to get communicated. But, when people sign up to be a patient at your clinic, they're going to be signing their HIPAA language. They're going to be signing some other basic office policy information. And you should also put in your payment policy expectations right there in the office policies. And this includes addressing things like if you're going to have a no-show fee, put that in there. If you're going to have a late fee for patients who don't pay on time, how much is the late fee and what is the time period when a late fee is added? And then, we've taken to the practice on the office policies of forcing people to initial some of those financial things, specifically the no-show fee and the late fee, a couple other things. However, Parker, this, and research-wise, we know this. People don't really read what they're signing, and even with it's probably worse with the advent of electronic signatures and PDF documents versus paper documents.
Right. I'm gonna click to sign, and then it's gonna jump to the next one, and then I'm gonna click again, and there could have been 7 pages in between those that I just didn't even read.
Right, right. And, it's, I was having a discussion. I try to be very reality based in what we're doing. And we were cleaning up some language in one of our clinic's office policies. And I felt like, should we just get rid of these 7 places to initial, because it's not really reality based that people are looking at it in close detail. I think the reason that's done is if there is a problem in the future for someone not wanting to pay, you send them the PDF with like, here's your initials that you agreed to this.
Right.
But anyway, it's just something that we're thinking about. You do need to have these items communicated. I would say if you're doing something non-standard or you're changing the rates, having a conversation with your patient is the only way, or best practices to really make sure a patient understands a change to the practice is a face-to-face conversation, and then having them physically sign a piece of paper that they've participated in and understood the conversation and were given a chance to ask questions.
Right.
But that is, if you're a solo practitioner without office help, that's a big chunk of time to have that conversation. And so that's not necessarily always feasible for all the groups.
Right. Right.
So I guess it's my way of saying, you asked, how can you make sure there's no surprises or misunderstandings? I don't think it's possible, but that doesn't mean there's not some best practices around that. Yeah.
Yeah. Best practices and little things that you can do to kind of make a difference, or at least remind somebody, or make them as fully aware of what the cost might be or what the policy is, especially in the case of a change.
Gotcha. Yep.
Yeah. So let's talk about, we did talk about common challenges when it came to collections. What about, there's multiple pieces of the financial puzzle when it comes to having a practice. There's the collecting from the patient, but then there's also, if you're taking insurance and submitting the insurance claim to the insurance company. So what are some ways that you can, avoid delays in payment collections, but also, what are some common challenges there?
Yeah. And this is another one that's gotten better over the years. And when you used to have to mail in paper claims to insurance companies and then wait for paper checks to come back, it was really, people would say, when I was starting up in 2006, they would say you need money to live on for 3 months because that's how long it takes to get your insurance reimbursement. And fortunately today, that is usually 7 to 10 days now. So that's a drastic improvement. And I think the biggest piece, if you're submitting insurance claims, is to have a good EHR that will scan your forms for the sort of blatant errors that result in automatic rejection. You want to make sure that you have the insurance policy ID and group number, if there is one, entered correctly. I think at Ripsy, we automatically do an eligibility check before patients are seen. And if nothing else, that will alert you if you've got the insurance, if the policy ID and group number somehow got in there wrong, or if the insurance policy has expired. Insurance cards, unlike credit cards, don't have a expires date on them. So patients often give you an insurance card that is no longer accurate. So make sure the basic information, date of births, and insurance card numbers, and a lot of that we can confirm electronically through the EHR like we do at Ripsy, make sure those are taken care of. And then I think the biggest, there's a question for people, right? You do an eligibility check and you'll see $20 copay, or you'll see 10% co-insurance. And then you have a decision to make. Are you just going to believe that, or are you going to submit and see what actually happens with the insurance company? And I'll say, people go both ways. At this point, our preference in our clinic is to do the insurance submission first, because we do actually, even a few days before you get your money, you'll see what the insurance company is going to do. So you'll know what the money reimbursement is coming and what the patient owes, often in less than a week. And rather than dealing with refunds to patients, we've just sort of made the decision, we're going to bill insurance, see what the actual payment required is. But then once we do that first claim and then we see what it is, we'll feel comfortable in collecting right at the time of the appointment. Our biggest the biggest surprise factor for patients at this time, which I alluded to earlier, is the rise of high deductible insurance premiums. Right. And what that means is, often when people are choosing their insurance plan, they see the cheapest, hey, this one only costs me $50 out of my paycheck each month, but they don't realize that it has a $6,000 deductible. And that means they're paying that first $6,000 of charges. And so we submit to insurance. It says, hey, the $300 for this visit is all being applied to the deductible. And then, hey, we're going to be charging you $300. And the patients are in an uproar. Like, wait, I thought you were in my insurance. And then you're the one all of a sudden, as like an HR rep, explaining, you see on your card where it says in-network deductible $6,000, that is what you're paying towards. And it happens over and over again that right. This creates the patient and family misunderstanding of their insurance plan, creates a lot of tension in this treatment environment. And so, we have taken to trying to alert people about, their high deductibles. Doesn't always work. But that is the biggest issue with insurance claims, is the people with the high deductible plans.
So what about in the instance of, any kind of specific delay from the insurance company? Is there anything on the provider's end in order to really try to mitigate possible delays as much as possible?
Yeah. So making sure that you submit your claims timely is the biggest feature, of course. I think once you have that first claim where you know what the patient owes, if there is some delay in the insurance processing in the future, which, it appears at random times, insurance companies may deny a claim that otherwise has gone through without issues. But as long as you know what the patient is paying, it would go ahead and you're able to go ahead and keep collecting at least what the patient portion is. For the insurance piece, this is a associated headache with just accepting insurances. Right. What we do, so in our software, the second a claim is rejected, it goes into a link of claims that were rejected. The good news is we usually see this within 48 hours that a claim has been rejected. And then we immediately alert the clinic, this claim was rejected. You click on it, and then you have different options on how to address it. Is it something you can repair right away on the claim form? Usually not, because we've hopefully prevented most of that. Is it something that's going to need an insurance call? Usually yes. So we give a little link to log your insurance call. Anyone who's done these know it's usually a bunch of time on hold. It's speaking to people. It's saying, hey, what happened? And they apologize for the mistake. And then you make sure you get a reference number at the end of the call. So if you have to call back again, you are not starting new. checking your accounts receivable and checking your accounting dashboard for payments that are overdue. So accounts receivable is, in visits for the last month, how much money is owed. In visits that are 1 to 2 months old, how much money is owed, and then 2 to 3, and then more than 3. But if you do nothing else, you shouldn't see money owed by a patient or insurance company really more than 30 days now. So if you're just even paying attention to your accounting dashboard, well, where is this money that's owed? That's a good way to capture that there's something going on with an insurance claim. But yeah, it can be a very frustrating piece. A lot of insurance companies do now allow you to submit a reconsideration for a claim online. We've been experimenting with this. So far, I think a phone call is still more effective at getting the money you're owed faster, but we'll keep collecting some data on this and maybe do a little research project.
In general, getting somebody on the phone is always going to be the fastest way to getting to your answers than a system that may not. I mean, hopefully that whatever online system you're using is factored in the specific situation that you're encountering, or is just designed well around accommodating something like that. But ultimately getting somebody live on the phone is always going to be the better customer experience, especially if they can say, I'm sorry that you're dealing with our system. No. And so people who've done this, you can, I'm highly recommending having a phone system that you can dial from your computer. Yeah. And, you sort of dial through your computer and you're going to be on hold. So you have some other administrative work that you can be cranking out. If you're all caught up on your patient notes, good for you. But if not, that's a good time to catch up on patient notes or update those office policies, make your web page more modern, and just while you're waiting on hold. And the actual phone call usually doesn't take too long. Right. Assuming you're not on 80-minute phone call, as we know, does happen.
Correct.
So I'm glad you talked about a little bit about what our system does when it comes to our claims center and handling rejections or claims that need to be repaired. That is something that we worked really, really hard on. So we love to promote that when we can. But on that topic of billing systems, how does somebody come to that decision of setting up an effective billing system for making sure that the payment collections are timely and accurate? What if they don't have the RipsyTech solution? What is it usually that somebody would go to the insurer's website directly, or what are the options?
Yeah, so there's sort of the phone number on the member's card that you can call. There is, if you can create a login for each insurance company to get access to claims and to submit claims if you're doing it manually, and to check on the status of different claims. A lot of several big insurance companies go through Availity. Cigna, Optum have their own. It's hard. It's hard to give both paths are reasonable now. It used to be you just had to call the number on the back of the insurance card to find out what was happening with the payment. Now you can usually create a login, and if you're tech savvy, maybe see what's happened with the claim ahead of time. But ultimately, resolving issues, like we just talked about, still feels better talking to a live person and getting a reference number. Yeah.
All right. So, if somebody's in their own private practice, then this is all something that they know that they can do on their own. If it's just them, then they hopefully they know what to do, or they're listening to our amazing podcast and it gives them all the information they need on how to do this effectively. But, say they've got administrative staff, front desk staff, as you mentioned earlier. How can practices train their staff to handle collections effectively and sensitively, especially when they might be dealing with a patient that's experiencing a financial difficulty?
Yeah, and there's a couple of things that we haven't discussed, and there's a difference between like sort of dealing with insurance companies that haven't paid you and still what to do about the patient collections. And there are people that charge before the visit at the moment of scheduling that have their patients submit a credit card payment to cover the cost of the visit. Again, this gets complicated because if you're using bill codes correctly, the charges can be different. And so if you're collecting something ahead of time, it might not always match. Or people adjust their billing practices to meet what was charged, which in general is not the correct way to do it. You need to perform the service and then see what the charge is going to be. Right. But I definitely understand the collecting a payment up front to avoid having to deal with it's usually a small percent of patients who don't pay, but it is still... there are going to be a percentage of patients that don't pay if you don't charge ahead of time, and that takes time and energy and is uncomfortable. So just wanted to point that piece out. I think, it is, again, from research in patient payments, we know that it is in everyone's best interest to offer payment plans and to be quick to offer payment plans, and being able to make the payment plan something that's very affordable for families and know that your clinic offers it is very helpful. Avoiding the ease of text messages and email messages around overdue payments and having an empathetic human voice. I think if you have office staff, office staff that come to work at mental health practices usually are kinder, gentler people. And so making sure that when someone is overdue on owing money or keeps leaving the office quickly without giving their copay, you're going to be empathetic, try to catch them. Hey, I noticed seems like you're having a hard time paying. Can we tell you about our financial aid process or payment plans? I think that when it gets to a point where, and every clinic would set a different dollar value that someone owes or a number of sessions, but when it gets to a certain point, you have to let the practicing clinician know that the patient is overdue on payments, because ultimately you're not going to be able to keep seeing people that don't pay for the services. And then all clinicians, all mental health clinicians, hopefully have the skills to talk about that uncomfortable topic, but in a direct and empathetic way with your patients. Well said.
So before I move on, is anything else that you'd like to cover on the overarching topic of payment?
Yeah, the kind of going back to, we've been putting a lot of, right, we've really streamlined the insurance collections piece of our product. And as you know, right now we're working on, we have our design for what we're doing to enhance the patient collections piece. And a lot of EHR companies have partnered with one vendor to do some of the payment collections. I think our motto for our EHR is to try to be flexible to what different practitioners like, sort of how we do with our telehealth piece. We don't restrict people to one product. We have it so if you like Google Meet or Zoom or Doxy, we can make that happen through the calendar appointments. And we've decided to take that similar approach with our payment processing. And I think our first three we're going to integrate with are Square, Stripe, and then QuickBooks. And so that different practices can still have their choice of the payment processor they like. And then, we can still, coming soon is going to be the ability, like you talked about, Parker. The second you see a patient, if the patient has given authorization for the credit card, you can click a button to bill that patient's preferred payment method, ACH, credit card. And that is important and critical for the practitioners and the practice. I will say that for people with a high deductible plan, or when you if someone is used to a 45-minute session and you did a 55-minute session, so the copay or charge is different, you need to be ready when you're clicking that charge the credit card, if it's not the charge the patient is expecting, or it's going to create problems for that relationship. And so I think these are the things we're trying to be thoughtful about as we implement our product. And I see us putting in when you click the charge patient's credit card, a warning for, hey, this is more than the patient is usually charged. Do you want to send a text message, wait to charge till you speak to them, and having some options like that. So since we want to make running your practice as smooth as possible, let's see if we can avoid a patient who's unhappy that you charge their credit card for some amount they weren't expecting. And that's what we're trying to be thoughtful about.
Right. Very well said. Very well said. All right. Well, we've talked so much about, insurance and payment collection, and that tends to be a recurring theme when we talk about the mental health business moment of the week. But and anything that you have in mind, and is it insurance related? I wonder.
I'm mindful of that. I'm like, let me not. Fortunately, I have a good non-insurance related one this week.
Oh, excellent! Let's go for it.
It's a EHR related issue, not with our EHR, of course, but we, in our nonprofit agency, we partner with some community-based organizations to see their patients. And anyone who's worked in the Medicaid or nonprofit realm know that you're often sacrificing administrative ease in order to see these patients, and most people are okay with it. But what we do is we do our notes and records in RipsyTech, and then we have to transfer them over to the other electronic health record for the community-based organization.
Oh, interesting.
And I won't name the product the other company uses, but it is not streamlined. It's very difficult to navigate. But the worst part about it is, I can find the patient I've seen, but you need a specific authorization for a certain behind the scenes program that the patient is for me to even enter my clinical record or note on the patient. And this just happened again this week. So it's very frustrating when you've provided care, you've documented, you want to get that record in, you want to send a prescription in to take care of the patient, and then you just physically cannot do it. And it requires email and a 3 to 5 day wait to both from IT, from the community-based organization, but then message to that EHR company. And this is like the fourth time that it's happened. So I was, again, ready to transfer my note, go over, pull up the patient, and then I'm just blocked with a drop down that's blank. Select program, click, just blank. And then that's it. Hey, couldn't the program go in later and I could at least get my note in? But anyway, so the email went off. It happened again. Can we please make it so I can enter my note for this patient? And that was my frustrating moment of the week.
Wow, that does sound frustrating. I don't think I would have been able to make that one up. Wow. All right. Very interesting. Very interesting. All right. Well, this has been a great episode. It's been fun as always, Dr. Tarshis. We will, next episode that comes out next week will be our first guest episode with Dr. Steve Kachi. It was a very, very interesting discussion that we had with him. Learned a lot about the history of his practice. So I hope people are looking forward to listening to that. Catch that next week. And then we'll be back to a regular episode after that.
Yeah, and I think, we'd love to hear stories about how people deal with patient collections and problems or conflicts or stories that they have, because it is, money is one of the big things that it's talked about a lot in therapy. It affects people's lives drastically, and we'd love to hear people's experiences. So at least with our product, we can try to make that piece of running your practice as easy as possible.
Absolutely. And any questions or stories of shared experiences that anybody would like to share with us that we could highlight on the podcast, send those over to sitandstay@RipsyTech.com. And we'll do an audience Q&A episode fairly soon.
Very good. Thanks, Parker.
All right. Have a good one. Bye.
Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.